So, so, I put out this picture one, of course, for the fact that he's my mentor and guide, but also clearly if he presented any of this, it would be a whole different flavor than I am going to. I'll stick to the facts. I'll stick to giving you tidbits. I will not be controversial. This is all supportive information for the larger sort of conversation we're going to have after Matt's conversation, sort of proposal which is going to get presented. So I'll be showing some data sort of supporting the 3D plaque work that we've done in PESA, a little bit about the polypool that we've been working with through Sinai with a Spanish company, just to put all the information out there for consideration when we talk about the design. So this is what's going on with the PESA study. This is an ongoing study with young bank workers in Madrid. Santander Bank folks, and this is an ongoing study. As you can see, almost a 10-year study. We're about a little bit over halfway done. These folks are getting cardiovascular examinations at periodic intervals and additional imaging studies. We are now gone through 2 rounds of imaging with the carotid iliofemoral ultrasounds. Nearly 1,000 people have undergone imaging with the FDG PET and MRI. Technology as well, also including the coronary calcium score. We have built into this, and I'll talk in a little bit, sort of some randomized trials for lifestyle intervention, trying to also look at the concept of trying to improve lifestyle behaviors based on some of the imaging data. So we're trying to accomplish a couple of things through this cohort. An added component is also collection of blood for proteomic, metabolomics, and genomic data, which is also ongoing. So this will be a robust cohort in terms of trying to understand subclinical atherosclerosis. So as I pointed out, we're a little bit over halfway done at this point, nearly over 4,000 patients. And we just recently published work relating to subclinical atherosclerosis, especially the 3D plaque data, as it ties to the coronary calcification and cardiovascular risk factors. I'm obviously presenting on behalf of the group at Sinai who's been carrying out all this work. This is just a quick snapshot. I will breeze through this because I think you need to also get to some more important stuff. But I think here is the money shot here. Tying back to the conversations we had earlier about sort of the concern, in fact, in some ways that Matt raised, which is that once you go through this kind of overall body scan for subclinical atherosclerosis, you pretty much get to everybody. And there's a large number of people, 64%, who clearly have subclinical disease once you get through multiple territories, and that this figure is sort of meant to represent that. Clearly higher in men versus women, again, not unexpected, this particular finding. Once we get, I think here is sort of another slide which tries to get again to the same point that was highlighted earlier. When you look across the board, it is very close to the 50% mark that we talked about earlier in terms of folks who have subclinical atherosclerosis, generalized vascular disease when you use 3D plaque. Here is some information regarding Framingham risk scores. And subclinical atherosclerosis by imaging. As you can see, if you look at the leftmost bars, again, very close to that 50% mark for low-risk subjects, and they can sort of be in some ways reclassified once you look at this, if that's the intention of that information. I don't want to get into this because I think Dr. Sillison obviously did a fantastic job of that. I'm not an expert at this. So let me just jump to some of our other stuff. Just to highlight the fact that we will also have significant information related to PET MR for the same atherosclerotic PET. I think that would be an interesting correlation for folks to look at. What I wanted to jump to was to show you guys a little bit in terms of...
Is this PET MR coronary MR?
No, this is aortic and carotid. Here is sort of our newest venture. Let me see how best I can try and show you some of this. This is the TANSNP proposal, and this is basically 4 studies in one that is being done as part of what is being done at Mount Sinai, at Sinai, and also in Chicago and Florida. Part of the study is a follow-up version of HRP that Dr. Sillison already presented. So the 6,000 odd people who received Plaque assessment will receive a follow-up assessment now, which will be nearly 7 years after their initial study. So that will be another robust assessment of clinical events and atherosclerosis progression and or regression for those people. We are following a similar model to what we did previously, which is try to use a mobile unit. In the previous version, as you saw, there was a state unit that was stationed there. In this case, it will actually be a mobile unit which can make house calls. So this is sort of the overall picture of the TANSNET program. I outlined to you one of the studies. The other one, as I said, is a lifestyle intervention study being carried out within the PESA cohort, a worksite intervention study trying to look at sit, stand, desk, personal wearable devices, and individual counseling versus usual care, if we can call it that. The third component is going to look at multimodal imaging, including 3D plaques, functional brain MRI, PET amyloids, coronary calcium scores, and trying to establish relation between that cardiovascular large vessel atherosclerosis paradigm with cognitive dysfunction based on neurocognitive assessment. Part of the goal being to establish some sort of large vessel atherosclerosis and functional MRI-based score that we can utilize to predict dementia and then use eventually in actually an intervention trial. And finally, as I said, across this program, blood will be collected for analysis for metabolomics, proteomics, and genomics, which is going to be done in Spain. The final sort of piece that I wanted to bring to your notice was related to the polycle work that we've been doing. So this is the focus trial. As you may or may not know, one of the other sort of major players in the polypill phase is Ferrer, which has also a triple combination pill with aspirin, ramipril, and they have a pill with atorvastatin and simvastatin. This is Focus, which was their medication compliance trial, basically looking at about 9 to 12 months. So I think one of the points I wanted to maybe highlight regarding Mark's paper in JAMA is that the clinical follow-up for events in most of these studies are relatively short. And I think that sort of reflects in the number of events, but also the fact that that estimate therefore becomes extremely unstable. Most benefits that you expect in any lipid or blood pressure trial usually sort of pans out beyond the 2.5 year mark, and none of these studies really have that kind of follow-up. So this is a modest sized trial, and I'll just jump to what is the relevant finding, which is that we did show a reasonable increase in medication adherence. This is a pretty strict outcome. The final primary outcome is related to patients actually showing up for that visit and then having a pill count, and in addition, adherence scale permit. And once you look at that, you'll see that there is a reasonable 10% increase in terms of adherence with the use of the polypills. Now, what that ties into is some of our other retrospective work that we've done now with the US health insurer Aetna, and show that same 10 to 12% difference sort of ties into about 25% relative risk reduction. So again, that's based on a retrospective study. I don't want to overstate it based on what Dr. Cole has already shown. But that's where we are sort of using that information to finally now proceed with an outcomes trial. This is being initiated in the next 3 months in Europe. This is a H2020 funded trial in elderly subjects enriched for cardiovascular risk factors, and will have nearly 3.5 years of follow-up. So this will be initiated at the end of the year in 7 European countries. I'll leave you guys with that.
Sri, I just had a question. Did the cardiovascular, I know the study was not powered for that. Well, was the similar direction unfavorable point estimate?
Mildly unfavorable, yes. So it is numerically trends in the wrong direction.
Which bothers me, because you would have, if the modeling exercises were right, you would have seen at least, not a 50, 60, 70%, but at least a 10, 20% risk reduction.
So you're absolutely right. I think the problem is that a lot of the instabilities for our study came from the revascularization data. The MI data, to my knowledge, that I've examined across the studies, tends to be pretty consistent in the benefit direction. And the same applies for many of the retrospective analyses related to polypill. So again, I think it's all a little bit of a wash, and I can see why the FDA, who's obviously much more concerned about the safety and the efficacy data in such kind of situations would stipulate and put those safety measures in place. It makes a lot of sense. We do have some pharmacokinetic data done back in 2009, and I think Ferrer is planning another quick US pharmacokinetic sort of study to plan for an FDA submission. So